And our first panelist to start is Professor Julian Leff from Institute of Psychiatry in London.
Thank you very much. I'll start without delay to get everything in 4 minutes. When I see a schizophrenic patient on my ward,
from inpatient care all the way out into the community, I think the baseline of this care is medication on the one hand and case management or individual therapy skills. I would say that for the treatment-resistant, very chronic patient, all of the above that I have just mentioned are relevant, plus I think you need to consider some form of asylum for these patients. Clinical research we need a lot more work in what we call service systems research. That is, the different systems that society sets up for the treatment of the chronically ill. And one of the things I could see coming in the future are studies of community living treatment alternatives for patients as an alternative to living in and with their families. I think in a way, I sense we're recapitulating history. It used to be that these patients were removed from their families, but also from society into asylums. With the community mental health movement, they moved back into supposedly moved into the community, schizophrenia, so that we could develop preventive strategies. And that would be, I think, a new kind of therapy, both individual and family, that could be very exciting and also tax our ingenuity and creative efforts.
Thank you, Tom. The next speaker will be Dr. Andrew Silver from Chestnut Lodge in the United States.
I'm speaking from the perspective not of a researcher dealing with numbers of patients and types of programs and strategies, but from the perspective of someone who's been an individual therapist with the patients, meeting with each patient 4 times a week over my 15 years of working at Chestnut Lodge. So my area of research and is more in terms of personal feelings and reactions. And I'd like to begin by saying that we very much look forward to hosting the next meeting of this symposium at Chestnut Lodge, and have very much the feeling that the Lodge represents a microcosm of the issues that people each individually are grappling with in their own treatment situations, so that I've found that this meeting has given me a feeling of connectedness with my fellow clinicians around the world, and this helped very greatly with a kind of a feeling of depression that many of us at the Lodge have been dealing with, and to find that we're not alone in that feeling, and then to get it into historic perspective that this is an aspect of the work, a constant feeling that something terribly precious is in danger of being lost, which is in terms of the understanding of the transference and countertransference and the aspects of the aggression in schizophrenia, and how that then manifests itself in the therapist, and how we each personally deal with what's stirred up in the course of the sessions. The way some of us at the Lodge have been feeling it is a mourning for the time when the patients could go through a period of off medication, and we could have a sense of being with them in their illness and reacting to it and finding aspects of our own illness resonating and so forth, and out of that forming a therapeutic bond. And having a sense, I mean, I personally feel that the results that my patients and I obtained earlier, when medications weren't always in the picture, were stronger outcomes. I hear from patients who were very psychotic, who now are married and are raising children and having careers, and having a feeling now that my work is more of supporting a veneer, kind of a psychic cosmetology kind of approach to things somewhat. So left feeling depressed about that. But then as I think historically, I think that what's happened is that a huge myth grew up about the work that was being accomplished at the lodge, and that the people who were working during the years that Tom studied in his very, very eloquent and elegant research protocol, they also were grappling with very severe depression as well. They weren't getting wonderful results, and they knew they weren't getting wonderful results. From Reichman talked about Joanne Greenberg as very much her star patient, and it was so gratifying after all those years to have such a result. What happened really, I think, is not so much that the results were so fine in terms of the clinical outcomes, but the results in terms of the understanding and the honesty in terms of confrontation, one clinician with another, the developing of theories of the intricacies of the dynamics. So coming to this meeting, at first I thought that whole structure was in danger of being lost, and I felt terribly depressed here as well as having felt terribly depressed there. As the meeting developed, as the focus, as the agenda moved from the general then to the family, and then to the individual cases, and there were some really magnificent case presentations of very enviable work, especially I think Francoise Devon's presentation moved me. I mean, I got to hear so few of the total, as everybody did. You had to pick 1 in 15 presentations. But those sorts of inspirational examples of excellent and effective dyadic work, and then the presentations yesterday on our evolving understanding of language in health and in illness. These inspired me and showed me that really we are gradually moving forward in understanding aspects of the human condition, and although these are economically troubled times and so forth, there still is probably the same proportional nidus of psychiatrists and mental health professionals interested in the sickest human beings, as there ever were. Perhaps even if we were to go back to counting numbers, there may actually be more people who are interested in this than previously. One other comment, I forget who it was, somebody in one of the Scandinavian countries was talking about how his hospital was in trouble because there were believers and non-believers who were working together, and that when you have a situation of both believers and non-believers, you've got trouble. If that were so, then the lodge is in trouble. There are believers and there are non-believers working along. I mean, believers in terms of the potential effectiveness of individual psychotherapy and in working towards actual resolution of the severe conflicts. I'm a believer, but there are others who believe that what we're doing is more providing humane asylum and so forth. I believe that such a dialogue, to have people who put themselves forth as believers and others who take the other pole and then the dialogue proceeds is as it always will be. And I hope that at our next meeting that those issues, as well as the issues of fitting the treatment to the patient and the patient's needs rather than our own personal needs for self-validation, that these issues of planning and treatment will come under very focused scrutiny in the next symposium.
Thank you. The next speaker is Professor John Strauss from Yale University, United States.
Thank you, Karen. I'm mostly impressed by our ignorance. I think that we have learned a lot, but mostly we don't know. Even the carefully conducted research in biological causes and medication treatments of schizophrenia they're valuable statistically, but I don't think we know about individual patients, whether this patient requires this or doesn't require this. And there's been a tendency to assume that because something works statistically, why it works for any given patient, and I don't think we know that. So I don't think we know much about the nature of schizophrenia, and I'm not sure that we know a lot more about the treatment. A particular area of ignorance, I think, is partly because schizophrenia tends to be such a severe disorder. I think we know very little about how to facilitate the patients taking over, and that so there's so much tendency in many treatment systems to control patients and not to facilitate their own autonomy and their own ability to make choice to the extent that they're capable of doing that. Because of this ignorance that I believe exists, I'm very suspicious when somebody says, well, this is what caused this person to become schizophrenic, or this is what caused them to get well. Often when a person talks about one treatment, I wonder what else is going on in this patient's life that we're not hearing about. So that it's that kind of thing, I think, that for me is very important. Rather than feeling pessimistic about that ignorance, I think in many ways it can be helpful because it can open up to inquiry and exploration. When we think we know and we don't know, we clamp down on possible exploration and new ways and new understandings. And I think that, as I see it, appreciating our ignorance allows for new things to be tried and new ways of looking at things to be entertained. This description of the tour group project are really evidence of people who are very good clinicians and have a lot of experience and broadening and broad range and heterogeneity of treatment that are provided in those contexts. And for that reason, I think that psychotherapy probably always needs to be viewed in the broader context in which it takes place. And therapy supervision of the case managers, that these people are often not very heavily trained and can use kind of psychotherapy understanding and psychodynamic understanding that people with psychotherapeutic experience can provide. I'd like to suggest, too, that in light of this orientation that it might be useful to change the name of these meetings, not just psychotherapy of schizophrenia, but something like psychotherapy and other psychological treatments of schizophrenia, so that we can broaden out a little bit the emphasis and begin to take in a broader range of treatment approaches, all of which are fairly well endangered these days and need a kind of bringing together and mutual support. So, in summary, then I think it's a wonderful time for exploration of intensive treatments and a variety of treatments, and that our main enemy is really not so much even funding, but it's in many instances our sense of certainty, which prevents us from looking into new possibilities.
Thank you. Although this session is meant to be a closing session or a part of the closing session, it is very important that this symposium and this session will not be a session of closure. In a field which is concerned about treatment and which has to contain so much pain as the field of schizophrenia. It is and has always been a danger of premature closure, both regarding theory and clinical practice. There will always be a temptation to think that we can close our research and stop to research for new knowledge. It's much easier to be a clinician if we have the feeling that we know all what we need to know about our psychotherapy. I can see several possibilities for pre-med.